I'm going to talk to everybody today about contrast enhanced mammography. So this is a little bit of a newer technology, and I'm going to talk about its usefulness in imaging breast cancer. For any of the guests, I'm Carrie Rochman. I'm one of the breast imaging faculty here at UVA. And disclosures, I do have some research funding from a company that makes a focused ultrasound unit, but I won't be speaking about that in this presentation. I do want to give a big shout out to the residency applicants that are on this meeting today and just tell everybody welcome. I wish we could all be in person, but hopefully you'll get a sense of who we are and what we do virtually. When you do your breast rotations at UVA, we are at an outpatient location. We're not at the main university hospital. So we have really awesome parking, and our facility is located in this big medical office building. We've been in this space for about a year. And on the inside, what's really cool about the rotation and when you come through is it's very multidisciplinary. So at our ribbon cutting last year, you could see me, one of our surgeons, medical oncologists, and some leadership from the hospital, all very excited to be in the same space. So we do imaging of patients in our space. The surgeons and plastic surgeons, geneticists, medical oncologists, they see patients in the clinic. And there's also an infusion bay, and we take up an entire floor of this building. And what's really great is that we're really enmeshed in this multidisciplinary care. So lots of communication between all the different docs. Something that I'd say also for our applicants is that when you train in breast imaging at UVA, it is hands-on. So you do your own ultrasound scanning, you do your own procedures, and you'll get a lot of teaching and learning along the way, but it's very, very hands-on. We've got lots of cases. We also train breast fellows, and we just alternate, whether the diagnostic cases, the residents are picking up their cases, the fellows are picking up theirs, and we go back and forth. So lots of hands-on training. So welcome to everybody who's joining us remotely. All right, so what I'm going to talk about today, I'm going to talk about what is contrast enhanced mammograms. What are they? How do we do them? What does cancer look like on a CEM? And then how is CEM useful for breast cancer imaging? So I'll talk about the primary detection of breast cancer using CEM. I'll talk about how it's useful to figure out how much cancer is there. Once we know that she has cancer, how much is there? We'll look at the other side, at the other breast, to see how it can help us. We'll see how we use cancer, how we use CEM for cancer follow-up for patients that are on treatment. And then I'll tell you about some limitations of the test, so we know when to use it and where our blind spots are. All right, so let's start with, so what is CEM? So CEM is contrast enhanced mammography. In older literature, it was called contrast enhanced spectral mammography. So the word spectral has kind of dropped off because it didn't really have much meaning. But it's a newer technology. So it's only been commercially available since 2011. So we've been using it for about a decade. And it's been kind of slow to gain traction. Like many new imaging technologies, it's got to be tried and tested. What is it exactly? Well, as the name implies, it's a mammogram that's performed with the use of IV contrast. And what's nice about using IV contrast in the breast, just like anywhere in the body, whether we're imaging the liver or the brain or whatever, is that you get the information about the anatomy. So the mammogram shows you what the structures look like, and then the contrast tells you what the physiology is doing. And what it's showing us is where blood flow is going. So we can see that contrast starts to accumulate in areas where there's increased blood flow. Tumors need a lot of nutrients. They're growing rapidly. There's neoangiogenesis happening. So you see tumors can be quite vascular. And that's this added benefit of the physiology helps us detect cancer better. All right, so how do we perform this test? So here's our unit and one of our technologists. So the patient gets an IV, and then she's hooked up to one of these power injectors, which is the same machine that we use in CT to get a bolus of contrast into her vasculature. After the bolus of contrast goes all the way in, about 2 minutes later, she stands up here at the mammogram machine and she has a mammogram performed. When the mammogram takes the images, it takes 2 images just sequentially, very quickly, one after another, 2 exposures. So one's at a low energy, which is just your standard mammogram picture. And then the second exposure is at a higher energy that's just at that K edge of iodine. So it gives you an image that's kind of iodine only. And then those 2 things are recombined to have this recombined image, which is what we use clinically. So the total time to do this is pretty quick. It's just like taking the regular mammogram images. Takes about 6 to 10 minutes, and we do want imaging complete within about 10 to 12 minutes because the contrast material starts washing out. So what do the images look like? So here's that normal low energy mammogram image. So a mammogram is an X-ray. So you'll see fatty tissue looks kind of dark gray. The whiter tissue is her normal glandular tissue. Here's her muscle and lymph nodes. Oh, here's a question for you guys. Can you see my little pointer on the screen? Or can you not see where I'm pointing? You can see it. Okay, perfect. Thank you. So on a standard low energy mammogram picture, we get morphologic information. What's happening here with this anatomy? And then here's this recombined image where we're seeing the iodine. So you can see the iodine outlines the blood vessels and enhances little vascular masses like her lymph nodes. This thing that looks like kind of a halo, this is a pretty common imaging artifact with some CEM systems. So on a normal study, she gets up and she has her CC pictures on both sides and then the MLO views on both sides. This would be the normal pathway through imaging for a CEM. So how does it help us? So what does cancer look like? So first, let's just remember what normal tissue looks like just on a normal mammogram. So here's a little picture, a little cartoon of what breast anatomy looks like. And then over here, we have 4 pictures of normal breast tissue. So normal breast tissue on a mammogram can be almost completely fatty. You can have a few little scattered bits of fibroglandular density. This fibroglandular density is the normal breast tissue, the stuff that makes milks and the ducts and the fibrous stroma that supports all those glandular tissue. So a little bit of scattered density. She's kind of heterogeneous, and here she's really dense. All of those are completely normal. So all of those density categories. But it can be more or less challenging to find cancer depending on what density category she's in. But just to let everybody know, this is what normal breast tissue looks like on a mammogram. All right, well, what does cancer look like on a normal mammogram? So cancer can either show up as a mass. So it's this 3-dimensional object, often with very kind of shaggy edges or little spiculated margins. Just always remember the word cancer means crab. It's like it has these little spiculated legs sticking out of it. So cancer, very run-of-the-mill invasive breast cancer looks like this on a mammogram. Cancer can show up as little calcium deposits when the cancer is necrotic. We see that a lot with in situ cancer. Cancer can look like architectural distortion, which are these straight lines. Instead of that nice kind of pattern of density that I was showing you on those other ones, we see these really straight lines happening. This can be more subtle and hard to detect. And then finally, cancer can show up because it looks like an asymmetry. It kind of looks like breast tissue, but it's very asymmetric to the other side. So this is an asymmetry, and all of these are different forms of cancer. So this is what cancer looks like on a normal mammogram. So now, how does cancer look on a contrast-enhanced mammogram? So here's a patient who has really dense breast tissue. She's young, she's in her early 40s, and her tissue is quite dense. This is a normal mammogram, but what's interesting is that she actually has very abnormal enhancement. So she's got this big area of white where all this contrast is accumulating here in the upper outer quadrant of her left breast. And on ultrasound, we were able to see a breast mass, and this turned out to be a high-grade invasive ductal cancer. So this would be an example where a normal mammogram would miss cancer, but with the addition of a contrast-enhanced mammogram, we were able to detect her breast cancer. Here's another image from a different patient who has, she's not quite as dense as the last lady, but she's got kind of this heterogeneously dense tissue. Again, her mammogram looks pretty normal. She's got a little oval circumscribed mass that has this little white thing as a little biopsy clip here next to it. But otherwise, it looks pretty normal. And what's interesting in this case, she has this pattern of enhancement that looks a little bit less 3-dimensional and less mass-like, but almost like there's just this enhancement of the normal tissue in kind of a normal pattern. And what we call that is non-mass enhancement. And non-mass enhancement is also a term that we use when we're describing breast MRI. What's interesting is that this mass that had a biopsy clip in it didn't enhance at all. It was just a little black dot, and this was a little benign cystic lesion. But this non-mass enhancement was ductal carcinoma in situ. So a couple different examples of what cancer looks like on a CEM. Benign masses, CEM can be helpful because we can see cancer that you don't otherwise see on a mammogram, but it's also helpful because benign things that are not cancer, they often do not enhance. So this is a patient who on her mammogram, she has a mass. She has this really oval circumscribed mass. And on the combined image, that reformatted image of the high and the low energies together, we see kind of just a void. There's really not much enhancement in the middle of this mass. There's just a little bit of a thin rim around the edge of it. And on ultrasound, this thing was just a simple cyst. So CEM can increase our sensitivity, but it can also increase our specificity. So you get gains in both. So we know that we see more, but is more information better? What we don't want to do in radiology is become more and more sensitive, but then become less and less specific, because what we really want to improve is our accuracy. So is seeing more with a contrast enhanced mammogram, is it better? So lots of studies have been performed over the years leading up to CEM's approval, and then since it's been out in practice, where we've compared CEM to just a traditional mammogram. And so lots of different studies, and initially with any technology, it usually starts off with kind of low numbers of patients. And we compared on all these studies, how was the sensitivity and specificity of mammography? How did that compare to a contrast enhanced mammogram? And so we look overall in all the categories, we see a shift toward improvement. So we see increasing sensitivity when you compare the two, and we see increasing specificity. So it really is improves our diagnostic ability in both of those categories. So when we're using it here in clinical practice, what do we do? So when we're first trying to detect breast cancer, women will come in for screening, and they can have a contrast mammogram at the time of screening. And in a separate lecture, we talk about the usefulness of this and some other modalities for screening. I'm going to focus more on the diagnostic side, but when someone's had abnormal screening, she can now have a contrast enhanced mammogram if she hasn't had one already. So how do we use CEM for screening recalls, and what's the data behind that? So this was a study that was put out in 2014, where it looked at comparing sensitivity, specificity, the PPV, and the negative predictive value for CEM, which is in our black bar, versus standard digital mammograms, which is here in our gray bar. And again, we see an improvement in performance across the board with CEM. What was interesting, and where a lot of our greatest gains are actually in this specificity and reducing our false positives. So things like cysts, we often have patients get called back for, and we do additional imaging for, but because those things aren't vascular and they don't enhance, our specificity greatly improves. So a big improvement here with downgrading false positives at the time of screening. So this was a different study that also looked at CEM for screening recalls, and what we see when we look at just mammography, we see the dotted line or dashed line, and then when we see here with CEM, we see the solid line, and so we see this shift toward up and to the left of the ROC curve. So we see improvement in both of those. So here's some more examples just from our practice. You know, the data is always interesting, but I know we're really image focused. So this was a 70-year-old lady, and this was her baseline exam. She'd never had a mammogram before. And this is the kind of mammogram where it's so busy, there's so many masses and things going on, you're just sort of like, oh my gosh, how am I going to tackle this? So she was brought back. She had just a normal 2D screening. We brought her back and did CEM for her diagnostic workup. But what you can see on this lady, just from her mammogram pictures, is that she's got multiple masses. She's got this big one on the right. She's got several over here on the left. And then she had some little calcium deposits, in addition to multiple skin lesions. So super busy. You know, this is kind of a challenging case just from the get-go. The little calcifications are up here. In this upper outer quadrant there on the left. And I'll just kind of zoom in on those because I know that's kind of hard to see at any resolution. And so when we brought her back, we did the CEM. And what we could see is that this big mass at the back of her breast didn't enhance at all. So this thing was just a cyst. This was early on when we started using CEM, so we did confirm with ultrasound that was just a cyst. She has these skin lesions, which are these things that are enhancing up here, and then just kind of the normal background enhancement. On the left side, she had some kind of low-level enhancement associated with those calcifications, and then some of these masses did not enhance. Those were cysts, And then she had one mass here at the front of her left breast that demonstrates kind of this low-level rim enhancement around it. So it was vascular and it had some solid parts. The pathology with her, the area of her calcifications were ductal carcinoma in situ, and this little enhancing mass at the front was a papilloma. But it can take these really complicated cases, especially when there's a lot of cysts present, and it can make it much more straightforward as to what's going on with her. And I will say one thing in her too, she also has a really challenging ultrasound exam because she's covered with these big verrucous skin lesions that trap air. So it's hard to get in a good acoustic window and be able to see the structures in her breast on ultrasound. So this was a really helpful exam to have for this patient who had an abnormal screening. What about the data? Here's some more data about CEM. This time it's looking at CEM versus digital mammogram for people that have symptoms. So this particular one was about women who came in with something that was palpable and it was suspicious on the palpable exam, and looked at the performance of a contrast-enhanced mammogram relative to the digital mammogram for women who had palpable findings. And again, we saw an improvement in the ROC curve and also an increase in both the sensitivity and the specificity. Something that was also interesting about this study is that CEM was better able to demonstrate the true size of the lesion, how big these tumors were. All right, so let's go and talk about not just detecting once we know cancer is there, but now the other thing that's really important for us to do in breast imaging, number one, is we have to find it, but then we have to figure out how much of it there is, because if we know how much cancer there is in the breast, it's going to really help guide her surgery. So she might need a small surgery, she might need a big surgery, but it's really helpful for us to be very accurate in telling the surgeon how much cancer is there so they can take it all out, but not take out a bunch of benign breast tissue. So let's look at the role of CEM when we're looking at the extent of disease in the breast where there's a cancer. So again, we'll look at some data. So here were a couple studies that compared the tumor size on CEM versus digital mammography and versus ultrasound. And then they compared it to pathology, and pathology was the gold standard. How big was it? And so what we saw is that with CEM, there was definitely an improvement in accurately staging how big the tumor size is compared to digital mammograms and ultrasound. And then the other tool that we'll use is MRI to do this. So how did CEM compare to MRI? Because MRI, we know, is actually the best tool at helping to figure out how big something is. So does CEM perform relatively close to MRI? And what was interesting is that there was no significant difference between size estimates when you looked at CEM compared to MRI. And this is important because, and why I really think CEM is going to be the future of breast imaging. MRI is quite costly, many, many thousands of dollars, and it uses gadolinium, which some patients don't like because of the potential for gadolinium retention in the body. So CEM is much less expensive. It's a fraction of the cost of an MRI. But if you can get the same information, I really think that this is going to help drive this newer technology. So it's an exciting thing. MRI is also really limited to areas that specialize in doing breast imaging. It's not really easily available all over the country. Whereas CEM, I think, is going to really take off because radiologists are really good and radiology departments are good at injecting iodine. And the learning curve to read these is not so steep. So I think that this is going to really improve access to care and improve care even in remote and rural areas for women. So it performed well compared to MRI. Now here's some cases from UVA. So this was a woman who had, we put this little triangle marker on her skin when she has something that she can feel, when she's got a palpable lump. And on imaging, she has this kind of big area of distortion. And we can see this tumor is at least this big, but it's kind of hard to figure out what happens here because the tumor interfaces with this dense tissue and there's no difference on mammogram. So is the tumor, does it come all the way out this far? You know, where exactly is the end point of the tumor when we're trying to tell the surgeon to take out this much tissue? On ultrasound, the whole thing was just really indistinct and ill-defined. It was hard to sort of lay it out in 3 dimensions. This particular person, she could not have MRI because of renal failure. She was on dialysis and she wasn't making urine, so we could use an iodine-based contrast in her. So here's an example of her, her images from her contrast enhanced mammogram. They give a much better depiction of not only where this distortion is kind of going lateral to medial, but also how far toward the nipple is this tumor extending. So we can now draw a line and help the surgeon figure out how we're going to remove all of this tissue. So a much better tumor size estimate here by using the contrast enhanced mammogram. This was a lady who had had an abnormal screening, and she had multiple little masses in her breast, a couple kind of tailing off toward the back kind of tail edge of the breast. And we brought her back and used CEM, and I think it just really nicely depicts, it just makes it so obvious where the cancer is. Here, it's a little bit harder to see because some of the little masses in there are obscured by tissue, especially this guy. I think this one out here really far lateral is really hard to see. But on the CEM, you can nicely see all of those little spots of what turned out to be a multifocal invasive ductal cancer. So very helpful for not only detecting the tumor, but how much tumor is in this breast. And with each of these things, we can do biopsy to prove what they are. This was another patient where we're having a hard time trying to figure out how big her cancer was. She had had a biopsy at an outside institution, got a diagnosis of cancer, and then came to UVA and came to see our surgeons. And so she has this mass back here. This little white thing is a biopsy clip. But she just has this kind of fuzzy haziness extending out in front of it. And with conventional imaging, just with ultrasound and mammograms, we were able to see kind of the dominant mass and one more mass kind of out in front of it. But it was hard to know, does the tumor kind of go, how far into this wispy stuff? Is this just some edema around a tumor, or is this tumor cells that are all around it? So she came in and she had her CEM, and we were able to see that mass, this little tail of stuff, but better understand where that ends. And then we also kind of focused our sights on some stuff a little bit more lateral that we didn't suspect at first, but that there was this kind of non-mass enhancement extending out laterally. And this little dot over here turned out to be more umor. So again, just gave us a much better understanding of where the tumor was. And why this is important is when the surgeon takes the clump of tissue out, they want to get negative margins. And so this particular patient, if she would have just had this area removed, I highly suspect that she probably would have had positive margins and would have had a repeat visit to the OR to clean out all the tumor that was in that breast. But here we were able to much better localize it and then plan for surgery appropriately. So what about the other breast? So when we know she has cancer on one side, does CEM help us with knowing what's happening on the other breast? So bilateral breast cancer is fairly common. We see it 1 to 3% of the time. So like, one out of every, 1 in 50 at least, maybe 1 in 100. We see so many hundreds of breast cancer patients here at UVA every year. So they're going to have bilateral breast cancer. Some of the things that increase your risk for getting a bilateral breast cancer, number one is if you have a lobular type of breast cancer, an invasive lobular cancer as your primary lesion. Also, if you're somebody who's just more likely to get cancer. So you've got a family history, you're young when you have your first diagnosis of cancer, if you have a known mutation, all of those things kind of make it more likely that you might have cancer on the other side as well. So this was that same case that I showed you from screening before, where we saw all these little dots on the one side. But what was interesting on her is that her left mammogram was normal, and she had a 3D mammogram. It looked normal. It just looked like normal breast tissue. But because she was having the contrast, we did it as a bilateral exam, and we saw this tiny little dot of enhancement over here on the left side. We took her over to ultrasound and evaluated that area. And sure enough, there was this little area, this little mass that was really indistinct and shadowing. This is what breast cancer looks like on ultrasound. And we did a biopsy, and she did indeed have bilateral breast cancer that was completely unsuspected at the time of her normal routine screening. So this really helped us find bilateral cancer. And what's nice in this case is that she doesn't have to wait until next year till the tumor grows and then go through the whole breast cancer treatment again. She can just have both surgeries the same day, both sets of treatments. It's a lot nicer for patients to not have malignancy be undiagnosed. And this was a little invasive lobular cancer. It was a different pathology than the other side, but we were able to find a bilateral cancer in this patient. All right, and so what about using contrast-enhanced mammos for cancer follow-up? So they're really helpful to also follow people that are on chemotherapy. Sometimes patients don't go straight to surgery. They get chemo first, and the goal of the chemo is to shrink the tumor so that they can do a smaller surgery. Sometimes also the role of the chemotherapy first is if she has a really high-grade tumor or if she has tumor in her lymph nodes, she will be more likely to survive her cancer if she gets the chemotherapy first. So we can help our colleagues in medical oncology, we can help them understand if their chemotherapy is working for this particular type of tumor. And then we can also see, has it shrunk so that now she can have a smaller surgery. So when tumors become necrotic on chemo, they get replaced by this really fibrous tissue. And the fibrous tissue, sometimes you can still see it on a mammogram. So sometimes it looks like the tumor shrinks, but sometimes it doesn't. And it's hard to know without having the pathology or looking at the microscope to know, is she just laying down all this fibrous stuff where tumor used to be, or has the tumor really gone away? So the physiology of blood flow and enhancement helps us understand if the tumor is really going away or if it's still there and not responding to the treatments. So what we see is that when we look at patients with neoadjuvant chemotherapy, we see if you compare a CEM to MRI, lesion size is really highly correlated with both of these tests, and that CEM is at least as reliable as MRI in assessing the response to neoadjuvant chemotherapy. So it's a good tool. Here's some pictures of that. This woman, her prior images are over here on the left side of your screen, and then the current ones after or while she's on therapy are over here. But she has this really kind of ill-defined area. She's got one biopsy clip in one of these masses, and this other mass, this helped us detect how much cancer she had. Again, her mammogram is not really impressive. It's hard to tell how much cancer is in here. But with the CEM, we can see that it's kind of this bilobed cancer where those arrows are pointing. She had chemo for several weeks, and then she came back for repeat imaging. And on the current exam, we could see the second area had undergone a biopsy, so there's a little clip there, but we see that there's a lot less of that enhancement. So this was a really positive response to chemotherapy. And now I would tell the surgeons, you might not have to take such a big area. You can take a much smaller area that's really focused on where those biopsy clips are, where the epicenter of the tumor used to be. So this was an example of monitoring response to chemotherapy. CEM is also super helpful when someone's had surgery already, and we're looking to see, has the cancer come back, or is there any residual or recurrent disease? So after surgery, there's a lot of scarring, and that scar tissue can look like architectural distortion that looks like cancer. So a CEM is really helpful because normal scar tissue really doesn't enhance. Very early on, immediately when there's a lot of granulation tissue within that first year, you're going to have some enhancement. That should be just kind of a thin rim of enhancement. But as the scar matures, when it's a couple years old, it's really nice to see through all this dense tissue and see that there's no enhancement. She's just normal. We don't see any signs of cancer in her breast. Ultrasound can be challenging around scars because the scars shadow like cancer. So this is, I think, a great tool, is looking at scars using a contrast-enhanced mammo. Which patients do we choose to use CEM for? I really like it, especially I really push for it when they have this dense tissue, if they're dense or heterogeneously dense. Also, if a patient might be high risk, but she can't get MRI anymore for whatever reason, often MRIs, if they're using them for screening, they actually stop covering it insurance once they have cancer because she gets classified as a cancer patient instead of a high risk patient. So I like CEM as an alternative for those ladies. I also really like it if you can't see her cancer initially. If her cancer was occult on a mammogram, I really like this to do her follow-up. All right, and then finally, let me just close here by talking a little bit about the limitations. So CEM is not a perfect test. There's some cancers we can't see, so we have false negatives, and then there's some things we biopsy that turn out not to be cancer, so we have false positives. So let's talk about some of these limitations, and just so you know, it's not perfect, but let's be aware of where it's going to help us and where it won't. So first of all, there are some people that can't get iodine. They can't get IV contrast. And so we just follow our current department protocols. And a lot of it's based off the American College of Radiology, how we're managing contrast. And it evolves as we learn more over time. But essentially, if somebody does have an allergy to IV contrast, if it's a severe allergy like anaphylaxis, then I don't give it. If it's kind of a low-grade allergy like hives, I've got to figure out the risk-benefit ratio, whether it's worth pre-medicating her. What's the risk of a severe reaction versus the benefit of having this test. In the screening setting, I almost never do it when there's an allergy just because she doesn't have known disease. But when she's a cancer patient, that risk-benefit ratio it changes. So things to think about, can she have contrast? If she's got acute kidney injury, we typically hold off giving iodine contrast when they're in acute renal failure. This is evolving though, as we have different limits for what the GFR is. If somebody's in chronic renal failure, meaning their kidneys are mostly shut down, but they're still making urine, if there is some preservation of kidney function, we don't give it to those patients because we're not trying, those patients will live longer if they're not completely anuric. It's a marker of mortality with chronic kidney disease. And interestingly, CEM was not created for using with patients with breast implants, and some of it has to do with the implant, how it looks, the timing of the exposure, and then the reconstructed image. Breast implants, just because they're this big foreign body, it can alter those dynamics. In practice, we've used it a few times with just kind of pushing the implant off the film and doing an implant displaced view. And the images have looked really good. So I see this evolving so we can start using this more for implants. But if you look at the white papers for the machines, it says don't use these with breast implants. But I think that's going to change in the next couple of years. So those are the limitations. And then let's talk about the false positives, the false negatives, and being able to biopsy stuff. That's kind of another big thing. Whenever we have a new technology in breast imaging and it's more sensitive and it finds stuff that other things don't, we also have to figure out how to get a needle to that thing. And so sometimes I can find the stuff on ultrasound, but there is a biopsy capability for CEM. It was only FDA approved in the past year. So for the first 10 years we had this, there was no biopsy capability with CEM. And we would have to use things like MRI or problem solving to figure out how we're going to get a needle to a certain area. But it is FDA approved and available now. All right, so false positives. So there are some benign lesions that enhance. Probably the most common one is a fibroadenoma. It's a benign breast mass. They can enhance. Also other benign things that are not cancer, things like papillomas, hamartomas, little intramammary lymph nodes, fat necrosis, or complicated cysts can also enhance. And so we will see some false positives with this technology. This was one of the earliest cases in my talk where she had just a normal mammogram. She had the big cancer up here at the top of her left breast. Oops. She also had some calcifications down here in her right breast, and that was DCIS, so she had bilateral breast cancer. But in addition to her 2 spots of cancer, she had this enhancing mass in the upper outer quadrant on the right. This thing was biopsied and it was a fibroadenoma, so this one was a false positive. Our other lady that I showed you early on, this little enhancing mass here was a papilloma. Papillomas sometimes are associated with cancer. We do remove those when we get that on a biopsy result if it looks suspicious, but it turned out not to be cancer. So this would also be a false positive in her case. So in all of breast imaging, we have false positives, and this modality is better than some of our other things, but we still do see some things that go to biopsy that turn out not to be cancer. You can also have false negatives. So there are some cancers that we don't see with a contrast enhanced mammogram. So this was a lady who had a little line of these calcifications that were detected on screening. And when we brought her back, we did the contrast enhanced mammo. But what was interesting is that there really was no enhancement associated with those calcifications. So we did elect to do biopsy for her because her imaging, her standard imaging was still suspicious. And hers did show ductal carcinoma in situ. And so one take-home message to also think about here is that the absence of enhancement shouldn't completely deter you from doing a biopsy if there is something suspicious. And I would say, especially in the like these calcifications, that this is something that's known to be a potential false negative. Another false negative that we can see in patients that have cancer, their CEM can also look negative if it's really low grade, and sometimes if it's a lobular type of cancer. So this woman had a breast mass that was actually pretty easy to see. It was just kind of sitting here in the fat in the medial part of her breast. We could see it on ultrasound. It was an invasive ductal cancer with lobular features. But when we did her contrast enhanced mammogram, that area didn't enhance, interestingly. So CEM will not find all cancers. It will find more than just conventional imaging, but it doesn't find all of them. So one of the tenets of breast imaging is something that we'll say is you go with whatever the worst feature is. So if you have something that is suspicious with other imaging modalities, sometimes you still have to biopsy it, even if something like a CEM or an MRI in that area is benign. So just be aware there are some false negatives. The other time that it can be difficult to see cancer is when her background tissue enhances a lot. So it's always hard to find a white ball in the background of white. And so here's her normal mammogram. She's super dense. Here's her contrast enhanced image. And all of her tissue really enhances. So it's really hard to pick out a tumor when the background of everything enhances so much. One of my colleagues had astutely noticed that she had this little edge at the back of her tissue. It looked like there was something that was a little bit mass-like. So we did evaluate it with ultrasound, and there was a little invasive breast cancer in that dense tissue at the back edge of her normal tissue. So this was another false negative on the CEM, and we just couldn't see it because everything around it was enhancing so much. So went through this lecture kind of quick, showed you a lot of cases, but hopefully what you'll take home is that, you know, contrast enhanced mammograms, it's a really exciting new technology. It's nice because we get this combined information of anatomy and physiology. We talked about the technique. The technique is actually, I think it's also why it's really going to take off is it's such an easy thing to add on. A lot of this CEM software you can add on to existing mammogram units. So it doesn't require the purchase of an entirely new modality for whatever radiology center that you're in. We definitely are more sensitive at finding cancer, whether she's been recalled because of screening, whether she's symptomatic. We're much better at figuring out once we know she has cancer, we're better at figuring out how much of it is there and accurately staging her overall extent of disease. We're much better at finding bilateral breast cancer when it's there. And it's helpful for us for following these patients to see how they're responding to treatment. But it's not perfect. No test is 100% accurate. So just know you are going to have some false positives and false negatives, and you can't really use it when patients have contraindications to iodine contrast. So that's CEM, and a bunch of references if anyone wants to go back and read about any of those studies. And thanks to everybody, and thanks to all of our applicants that are joining us. And I hope that we get to see you in beautiful Charlottesville, Virginia in the future. So, and at this point, does anybody have any questions? I'm happy to stick around and answer any questions that you might have. All right. Well, I wish we were all in a room together, but it's really lovely to see you, and have a good rest of the day. Jordan, I'm going to stop sharing if that's okay with you.
Great. Thank you so much.
Thank you, Dr. Hartman.
All right, guys. Have a great day.
Thank you. Thank you.